Right, I think you've got quite a bit of how to analyze gases, acidosis, alkalosis. Both we have seen, and analysis, and just we'll look at some examples and again reiterate the steps that we use when we are analyzing the gases. Again, as I told, that clinical setting and blood gas, both are different, but we have to always try to correlate both of them. Only then can we reach to a proper diagnosis. Suppose let's look at this one, a 4-month-old female child admitted with a clear-cut history of loose stools. Here it has been going on for quite a while, so 1.5 months. Fever and vomiting last 2 days, failure to thrive, received multiple antibiotics. On ER, we found that the child is having some dehydration with perfusion relatively maintained. The blood pressure is maintained here. So we look at blood gas, pH is 7.31, CO2 is 28, 41, bicarb is 14, we have electrolyte values also. So what could be the possible reasons for acidosis and further investigations? So what is this setting? Clinically, what do you think could be the cause of, we have acidosis, pH is 7.31. So what is the most common setting is of?
Chronic diarrhea.
You can say relatively chronic diarrhea. So diarrhea is definitely there and some hypoperfusion is there. We don't know about the respiratory status, has not been mentioned here. So the setting is of loss of electrolytes and bicarb from the body. Setting is of a metabolic process. Now let's look at the blood gas as such, whether it correlates with that. So here we have a pH is 7.31, so acidosis we have. And if you CO2 is 28, bicarb is 14.3. So going by that what we have learned, CO2 is 28.7. So CO2 is low and pH is low. So it's just opposite effect, but ideally it should go in opposite directions. PO2 is 41, is a blood gas, venous blood gas, and bicarb is 14.3. So as we have seen that bicarb and pH go in the same directions. So pH is low, bicarb is low, so it's like the elevator effect. So therefore this points to a metabolic cause here. Second, next up we look at the electrolytes. Sodium is 136, chloride is 116, lactate is 1.95, anion gap is 10.8. So here anion gap is not raised. So you can, by looking at if the anion gap is normal, that means in this case of acidosis there is no increased anion gap acidosis. It should be explainable by within this parameters that we have. So it should be a pure normal anion gap acidosis. And the second step that we need to do is look at the CO2 levels. So primary cause here is metabolic, so pH is low, bicarb is low, and let's look at the CO2 value. CO2 value is low, so CO2 has been body is trying to compensate. So if for pure metabolic acidosis, CO2 should be as per the formula. If you apply it, 1.5 times bicarb plus 8 plus minus 2, should it be range into 27 to 31. Here it is around 28.7. So we can say that there is no additional respiratory component is there, and after compensation the CO2 is falling within the expected ranges. So this case becomes like a normal anion gap metabolic acidosis. Now let's look at another case. It's a 1-month-old male child presented with acute history of fever, fast breathing and poor oral intake since 3 days and decreased urine output since 1 day. Parents have not noticed any abnormality before that, so they are giving just the acute history. On examination, child is drowsy, sick looking, tachypnic, bilateral cracks are present, retractions are present. To look at the respiratory rate, it is 70 per minute. Heart rate is child is tachycardic, CFT is just about slightly getting prolonged. No murmurs, no organomegaly, tone reflexes, other activity is fine, but the child is drowsy and sick looking. This is the flush blood gas we get in the ER. pH is 6.83, grossly abnormal. PO2 57. We have to decide as far as the blood gas what could be the causes. So child is CO2 look here is 9.6, bicarb is 1.6. So this CO2 cannot be the cause of this low pH because it goes in the opposite direction. Bicarb is only 1.6. The bicarb has fallen, pH has fallen. It's a pure metabolic problem, and CO2 must have been this body is trying to compensate. So CO2 is very, very low. And additionally, again we'll have to investigate further. because the child is having hypoperfusion and very very low pH, we will have to give some fluid resuscitation, ideally starting with the isotonic saline, and in this particular case probably bicarb will have to be considered because it's extremely low and child could end up in shock if it's uncorrected. But remember that giving bicarbonate for metabolic acidosis, there are only very very few indications, and we should be very very careful before deciding about giving bicarbonate to treat metabolic acidosis. So here what happened, these are the sequential blood gases. The first pH we had a 6.83, bicarb was 1.6, sodium 148, potassium was 2.6, chloride was 118. Some normal saline and bicarb 1 milliequivalent per kg was given. I have not mentioned here. 1 milliequivalent per kg bicarbonate was given. After the second blood gas, bicarbonate has now risen to 4.7. pH has improved slightly, and as you can see, CO2 is also now increasing. So progressively, as the child continued to receive fluid and bicarb, the bicarb continued to rise and pH slowly normalizes, and CO2 component that was child was hyperventilating, now it slowly it comes back to the normal ranges. If you look at this, try to calculate the anion gap. It is not being mentioned here, but it will come out to be normal anion gap. So what do you think this child has? Creatinine at arrival, this child on arrival had a creatinine of 0.89, which was very high, because after resolution of the situation, the creatinine ultimately came down to around 0.43, so 0.38. So there was some acute kidney injury also on top of that. But the child, they did not give the history, but the child had a history of this repeated problems. So this was a case of, as per the blood gas, it's a case of a normal anion gap metabolic acidosis hyperchloremic, but this was a case of renal tubular acidosis, and this child ultimately is doing well on oral bicarbonate supplementation. It is perhaps the only indication if you give. Sometimes there are only very few limited indications in which you give it. Now look at one more case.
So what you saw, a pH of 6.8, 6.9, if that kind of pH comes, there are very few reasons where the patient is going to survive. If it is near the end, then of course pH can be anything. Inborn errors of metabolism. A younger infant, then that is our first diagnosis. Second, if it's an older child, more likely decay. Others like renal failure, RTA, renal tubular acidosis, rarely going to just such severe acidosis. This one has gone because there is an acute kidney injury on the top of the renal tubular acidosis that was going on. So if you take everything together, then this can be one situation. In fact, all three can be situations where temporarily a small dose of bicarb may be required. In no other situation is bicarb required. Bicarb is harmful to the body in most of the situations when given like that. A chronic bicarbonate therapy in a patient who's got a renal tubular acidosis taking bicarb tablets at home, that's a separate story. But I'm talking about acute conditions where you are in the emergency room or in the ICU. Sorry, I'll have to cut you short, and we have a dire emergency in the hospital. Both of us will have to leave. We knew the patient is coming. We thought he started from Karnal. We thought it will be late, but they have reached, and the video sent to me shows it's a severe respiratory problem that the patient is having because of foreign body aspiration, which we'll have to go and extricate. All the other people are ready. I'll just take you through what I was supposed to tell you in a presentation. Just most of this is repeat of what we have already told you quickly. Okay, what are normal blood gas values? We all know. We have seen this seesaw effect. We have seen this. 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 Okay, we have seen these things. How these things move with each other. In which direction they go. Okay, sorry. It should have started somewhere else. I have started too early. Yes. So there are 10 commandments. Who gave those 10 commandments to whom? Okay, you all, if you're not Christians, it's okay. So we'll take some examples and see what were the learnings. There'll be not a complete picture of the patient, just a little bit, and learning from that. This is ABG value in a 1-year-old child who has mild respiratory distress, done as a part of routine workup. Our residents are very fond of doing routine workup. And the patient comes, sir, sab kuch bhej diya hai. Very good. So pH was 7.38, PCO2 was 42, and O2 47. So, what did we learn from there? I shall confirm that the sample sent is a arterial and not a venous sample because PO2 was 47 in a normal looking child. It cannot be. There must be something wrong. So, God has told us, thou shall not. Instead, we will say what we have learned is, I shall not. So, this is, why it has occurred. Okay. A 7-year-old was admitted with encephalitis 2 hours later when clinically she was deteriorating. Clinically she was deteriorating. A repeat blood gas was done to decide whether we should ventilate or not. pH is 7.4. 2 hours later it was 7.39. PCO2 which was 42 is now 10. And O2 which was 82 is now 148. Clinically the patient is deteriorating. What is this? I shall use only minimal amount of heparin to rinse the syringe. Otherwise, this is what can happen. Excess heparin causes the PCO2 to go low and the O2 to rise towards 150. This is because of excessive amount of heparin. Dr. Manish told you that take some heparin, flush out everything out of the syringe. Whatever is coating, that is enough. Okay. ABG value of a child with cyanotic spell. pH is 7.54, CO2 is 21, and O2 is 88. What's wrong in these values? Somebody in cyanosis cannot have a PO2 of 88. Impossible. Right? So why did it become possible? Because I shall make sure that there are no air bubbles in the blood sample that I sent for ABG analysis. ABG value in a child with staph pneumonia with improving respiratory distress. Previous case was deteriorating. Here the patient is improving. pH at present is 7.32, but 12 hours earlier it was 7.38. CO2 is 46, now it was 40 earlier. O2 is 63 now, it was 78%. Hemoglobin of the child is 6.8, TLC is 32,000, polys are 84%. What is wrong? I say the patient is improving, but 12 hours earlier, its blood gas was better than what it is now. PO2 has fallen. CO2 has risen. I shall send the sample in ice and analyze it quickly. And keep the TLC in mind, especially when there is a delay. This 32,000 cells are eating up the oxygen. And that is why oxygen looks less than earlier, which actually clinically is telling us it's not true. So when there is no poor correlation with the clinical situation, please look at the whole thing more carefully. Bronchiolitis, moderate respiratory distress on arrival from another hospital. pH is 7.62, PCO2 60, O2 is 76, and bicarb is 48. pH is high, alkalosis. CO2 60 cannot be the cause of alkalosis. CO2 60 would have caused acidosis. PO2 is 76, reasonably okay. Bicarb is 48. Where did this bicarb come from? The other hospital guy must have given it. I shall always take the history of sodium bicarbonate administration even in the respiratory cases. We know for respiratory cases it is not required, it is harmful, and yet we know that many of us ourselves, by our own hands, order it. Wrong. Case of bronchiolitis not improving in spite of aggressive management in another hospital. Now it's transferred to you with a pH of 7.51, CO2 is 45, O2 is 68, and bicarb is 38. Hemoglobin is 10.4, TLC is 9,600, sodium 138, potassium 1.8. So pH is alkaline. CO2 cannot account for it. It is high. It should have caused acidosis. PO2 is reasonably okay, acceptable on whatever oxygen is getting. Bicarb is 38, too high. So bicarb must be the cause of the high pH, and CO2 which is rising is trying to compensate for it. But I shall always consider the effects of furosemide, steroids, salbutamol, blood transfusion, and hypokalemia, all of which can cause alkalosis. They may have given high bicarb, they were obviously giving Lasix, may have given high blood transfusion with a, so on. So think of all the interventions. Are they the cause of abnormality that we are seeing? Is it not the true pathology? Okay. 5-year-old with severe blood bilateral pneumonia, clinically worsening in spite of your treatment with oxygen. On admission, pH was 7.34, next day it is 7.31. CO2 is 42 and now it is 47. O2 is 66, yesterday and today it is 88. But clinically is worsening. How can this be that O2 has risen? Clinical worsening, definite worsening. I shall always take the FiO2 into consideration. Yesterday he was on 20%, today is on 60%, so obviously his O2 has risen. I shall also look at the PCO2 values, and you see the PCO2 has actually risen, 42 to 47. So he has worsened. For every 1% of oxygen that you give, multiply by 5, that should be the approximate PO2 value. 20% oxygen gives you a normal PO2 of approximate 100. So if you make it 60%, the PaO2 should be something like 300. Multiply 5. If that is not happening, there is something wrong. Okay. 8th case. A 5-month-old cerebral palsy child is brought in respiratory distress since 1 month age due to recurrent respiratory pneumonias. APG values today is 7.36, PO2 is 62, CO2 is 62, and PO2 is 60. Phone call comes to me, sir, I am going to start on ventilator. Should it be pressure limited ventilation or volume limited ventilation? So what do you think? The pH is 7.36 and the CO2 is 62, PO2 is still acceptable, 60, not 50, less than 50 is called respiratory failure. So if you give more oxygen, probably O2 will rise. What about CO2? It is 62. Should we ventilate? pH has compensated. It is 7.36. It has come to normal range. We don't need a ventilator in this patient. It's a chronic disease. Remember, the child is having a recurrent and a persistent disease. I shall take the history into consideration before instituting therapy for chronic respiratory failure. Here, it is not required. A patient with Guillain-Barré syndrome on mechanical ventilation suddenly deteriorates with the SpO2 falling and the EtCO2 rising. EtCO2 is what is being measured continuously and comes on the monitor, and tidal CO2. Initial pH was 7.37, now it has fallen to 7.19 because, and the PCO2 is 35, it has now become 58, and O2 is 88 and 47. So what has happened? Tube block, very good idea. I shall always remember the acronym DOPE. DOPE stands for displacement of the tube, obstruction of the tube, pneumothorax, or equipment failure. When something like that happens suddenly. My last commandment. There are 10 only. A 3-year-old with septicemia, multiple organ system failure, ARDS, has the following ABG when clinically stable on a high PIP and PEEP. pH is 7.36, CO2 is 44, O2 is 58. Both PIP and PEEP were increased. What should have been done? Even if you don't use a ventilator, you know the answer. Look at the 3 readings given. 7.36 within normal range. CO2 44, normal range. PO2 58, given ARDS patient, it is acceptable. So we don't need to change any ventilation settings. This is acceptable given the circumstances. And what we learn is, I shall practice gentle ventilation and not try to bring ABG to absolute perfect normal. Know what is acceptable in a given situation. Here, this is a given situation. This is acceptable. Thank you, and please allow us to leave. There are other things. There are 2 people there. They will take you through. Nothing will be missed. It's just that we change the order. I told you the reason. Sorry for going through this so quickly. I hope you would understand. Thank you. Dr. Manish, and I'm leaving Dr. Rohit and Bilal will take you to the sodium and potassium and all those things. 1 minute.
Hi, thank you, sir, Dr. Manish, Dr. Chuk, sir, for a wonderful presentation and for showing us how to take the ABG samples and interpreting the ABG report so wonderfully. They have to leave for an emergency. I request Dr. Kaba, sir, to honor Dr. Krishan Chuk with a memento. वो बैकड्रॉप लगा दो ना.
I was supposed to wear this kind of coat. I tried to match it with the shirt.
Yeah, it's looking very nice, sir.
ऐसा तुम भी आ जाओ नीचे.
I request sir to please also present a memento to Dr. Manish. Thank you, sir, for sparing your valuable time.
Hello. Next session is for
The organizers, the great team here, or the participants here, and they will enjoy it.
next talk will be Dr. Rohit, please.
So we are done with ABGs. Now we'll start the fluid and the electrolytes. So first with fluid. So what is the most abused drug in the hospitals or by the doctors? No, it's actually oxygen. The second is fluids. Okay, so we'll try to use fluids more appropriately. Now fluid is a drug, and with every drug it should be used cautiously. Excess of fluid is bad. Now fluid overload is related to increased mortality and several other complications such as pulmonary edema, cardiac failure, delayed wound healing, tissue breakdown and impaired bowel function. Just because a child has come to a ER doesn't make fluids to be warranted, and even oxygen. So as we know, our total body water accounts for 60% of the body weight. Out of that, 40% is intracellular, 20% is extracellular. Plasma accounts only for 5% of the body weight, rest is interstitial. So we are trying to manipulate only the plasma volume, which is only 5% of the body weight, and rest are managed accordingly. So fluid therapy is usually of two phases. First, they are replacement fluids, and second are maintenance fluids. Now replacement fluids are given to replace the losses, and maintenance fluids if the child is not eating well, or if you have kept him NPO for any procedure or surgery, then you give maintenance fluids. And there is a difference between both types of fluids which will come on later on. Now coming to the cases, okay. Now 11-month-old male child presented to ER with history of fever, coryza and fast breathing. At the time of presentation he was irritable, slight tachycardia, tachypnea, saturation was a bit low on room air, 92%, and with minimum recession. Bilateral air entry was good. There were some crepitations as well as a rhonchi, and a viral panel was sent which showed positive for RSV. So you diagnosed to him RSV bronchiolitis. Now what will be the choice of maintenance fluids in this case? Now he is not eating. Which fluids will you prescribe? N/2 DNS. And how much fluid? Suppose he is 10 kg. Holiday cigar formula. So we have a tendency to prescribe N/2. Why will prescribe N/2? Okay. Okay, so we'll just discuss all things. If we see our plasma sodium is 135 to 145. Okay, usually it's maintained in a very tight range. Normal value is 140. Potassium is 4 to 5 and chloride is 94 to 111. Now DNS contain 154 sodium, 154 chloride and 5% dextrose. Half DNS contains 77 sodium, 77 chloride, no potassium. Isolite PVC is 26 sodium, 2.1 potassium, 21 chloride, and N/5 DNS, which is rarely used, I think, contains 34 sodium. Now for a serum sodium of 140, we are prescribing N/2, which contains serum sodium of only 77. So what we are going to get? We are going to get hyponatremia, and that will be iatrogenic hyponatremia, which later Dr. Bilal must be taking on. So the choice of fluid are not hypotonic or hyponatremic. We should provide isonatremic fluid. So the fluid of choice is DNS, except in neonatal age group, whereas in neonatal age group also it has been said that they have an increased sodium demand rather than a decreased sodium demand. And I like to restrict my fluids because I started this lecture by saying that excess of fluid is bad. We always overestimate the fluid requirement rather than underestimating it. A child is a case of respiratory problem. If you give too much of fluid, there will be pulmonary edema. There will be fluid overload. His work of breathing will increase. And secondly, whenever the child is in a stress state, they try to retain fluids of our own body. So as much as possible, always try to restrict fluids. Now we come out to the second case. Now 8-year-old female came with high-grade fever for 5 days, decreased oral intake, and now decreased urine output for 4 hours. At the time of presentation, the child was tachycardic, tachypnic. Her blood pressure were on the lower side. Her CRT was prolonged, and saturation was a bit low on room air. And even peripheral pulses were feeble. So you diagnosed to have a shock. Okay. Now earlier we were talking about replacement fluids because the child was okay, he was not feeding, so we were given maintenance fluid. Now we need to increase our intravascular volume, so we'll give replacement fluid. Okay, so you started her on oxygen and IV cannula was inserted, and this was the VBG done. pH was 7.25, CO2 was 39, fairly okay. Bica was a bit low, 18.4. Chloride was 116, and there is lactic acidosis. So it is metabolic acidosis and lactic acidosis. So what will be the resuscitation fluids? Yes? Ringer lactate. Okay. And anyone used to like any normal saline? Why you prefer ringer lactate and why you prefer normal saline? Yes? Hyperchloremia. Chloride is 116, not very high. Okay. Actually, there is some lactic acidosis. So ringer lactate should be avoided in lactic acidosis, though you can give. But what happens if you give more of ringer lactate and lactate starts to rise? You are not very sure that lactate is rising because of my fluid or our child is worsening. NS is a good fluid. Okay, usually anyone like to give any colloid, dextran, starches, albumin? No. Okay. And there is a new fluid which is plasma light. Plasma light means like plasma. Okay, so it's a very good fluid. We'll discuss about it later. And how? Now, what will be the amount of fluid which we're giving? 30 ml per kg or 40 to 60 ml per kg? And how much time should we give? 30 ml per kg. Over? 30 ml per kg per hour for first 3 hours. So 90 ml per kg. First 2 hours. So that's 60 ml per kg. No? Okay. Earlier we used to give lots of fluid in a child of septic shock. We used to give approximately even up to 90 to 100 ml per kg. But now we are in conservative fluid therapy. We should restrict our fluid management. The latest pediatric sepsis guidelines recommend 40 to 60 ml of kg of bolus if you have an ICU setting and if the child is hypotensive. If the child is not hypotensive, just tachycardia, you don't give any replacement fluid. And the latest adult guideline says 30 ml per kg over 3 hours. So it is 10 ml of fluid boluses every hour for maximum of 30 ml per kg. But sometimes we give even less, 10 ml per kg or even 15 ml per kg, and we try to start early inotropes because as we discussed earlier, excess of fluid is bad. After every bolus, fluid bolus, which is only 10 ml per kg these days, you have to assess, should I give more fluids or I should restrict my fluid and start early inotropes, because fluid will ultimately cause more harm than good. If you give too much of fluid, then you have to remove it some way or other, and increase in fluid cause increase in renal failure. Now these are again the normal plasma. These are the normal saline, which we all know contain 154 millicuries of sodium and 154 millicuries of chloride. Now ringal lactate is a good fluid, except when your lactates are already high. It is more balanced than NS. But there is a new fluid which is known as plasma light. And plasma light concentration, if you can see here, it contains almost all electrolytes which are very close to the normal plasma. That's why it's called plasma light, means like plasma. So if you want to give large volume of fluids, 30 ml per kg or 40 ml per kg, so if you give plasma light, it causes decreased chloride levels, because if you see chloride levels in plasma light is only 198 as compared to 154 of NaCl, and moreover the plasma light don't contain any lactate, so your lactates also don't rise. It contains small amount of acetate, and if your liver is working well, this acetate will ultimately get converted into bicarbonate. So you will be giving some amount of bicarbonate through a very judicious use, and your pH is better. And we know now Hypo Hyperchloremia, if you give large amount of NaCl, it will cause hyperchloremia. So that causes increase in acute kidney injury, and it causes electrolyte disbalance, hyperchloremic metabolic acidosis, and it can even cause some metabolic derangement like increased PTA, PTT, and can, especially in a sick child, it can cause coagulopathy, and there is increase in mortality. So resuscitation fluid will be crystalloids, not colloids. We can use colloids if we have given large amount of crystalloids. After then you can give a colloid bolus, and dextrans, starches are not recommended because they also cause coagulopathy. Choice of fluid is plasma light preferred over NS. Amount of fluid is only 30 ml per kg, and you have to give that over 3 hours. Now the third case. 7 months old male came with vomiting and loose stool, and he was a case of dehydration. He was tachycardic, tachypneic, lethargic, stint was delayed, oral mucosa was dry. So we all know WHO plan for severe dehydration. If the child is in shock, he is having low BP, then you give a bolus. And otherwise, you give resuscitation fluid of 100 ml of kg over 3 hours if the child is more than 1 year, and if it is over 6 hours if the child is less than 1 year. And you have to assess after every 3 hours and replace the ongoing losses. Now here we'll discuss about the fluids again. Now which fluid should be used to replace the stool? NS, RL or plasma-lite? RL. So preferred fluid to replace stool losses are RL. But you can use plasma-lite as well. Okay, NS should not be used. And maintenance fluids? Usually maintenance fluid in these cases will depend upon your sodium level, which will come later on. If the sodium level is very high, then you have to change your maintenance fluid. The maintenance should contain some amount of dextrose. The replacement fluids usually don't contain dextrose. Okay, so you can use DNS or NS depending upon the situation. And how to replace the ongoing losses if the child is having stool. So again RL or plasma-lite, or you can replace if the child is taking orally with oral ORS. Okay, and case 4. 3-year-old male came with burns, 30% of burns. Okay, he was having some tachycardia and tachypnea probably due to pain. Saturation was 96. Good peripheral pulses. CRT was less than 3 seconds and BP was okay. He was irritable but was responding to commands. So how will you manage this case? What should be the fluid therapy in a burn patient? First, we should assess how much is the burn area. Fluid therapy in burns depend upon how much of the body surface area has been burned. So this is a rule of 9. Head and neck constitute the 9% of body surface area. Right arm 9%, left arm 9%, entire trunk front and back is 18 and 18, so compares 36. Groin is 1 and each leg is 18%. So this is a Parkland formula. There have been some other formulas, but this is the most commonly used. So we have to give 3 ml per kg of body weight plus the total body surface area of the burn tissue in the first 24 hours. So there is also a 4-to-1 rule which we'll add because of the maintenance fluid which we are saying, holiday cigar. So 4 ml per kg over first 10 and 2 ml over the next 10 and 1 ml after 10. So you have to give both the fluids, maintenance as well as the replacement, because your insensible losses will be increased. You will give more fluids on a burn child, especially in the first 24 to 48 hours. Now this is the 5th case. A child has come to you post-operatively after appendectomy. Now he is shifted to PICU. Okay, and he is extubated. His heart rate is 160, respiratory rate is 38, fairly fine. Saturation is maintaining, not room air. CRT is 3, peripheral pulses are palpable. Now, what is the choice of fluids in post-operative patient and how much fluids? Anyone? It's a simple post-op case. DNS. And how much fluid should we give? Uh, 20%. See, usually we give full maintenance fluid in post-op patient during the first 2 days of surgery. We don't try to restrict fluids because there will be insensible losses. But if he is not maintaining good urine output or his BP is falling, then you can add some replacement fluid to maintain the intravascular volume. You don't need to increase the dextrose. If you are increasing the DNS to 120%, you are also increasing the dextrose which you are supplying to the body. That doesn't need to be increased. You can give intermittent boluses of NS, okay, just to maintain the intravascular volume, because there will be a lot of third spacing in the first 2 or 3 days, and then gradually he becomes to better, and then you will try to decrease your fluid intake. With fluid, we follow ROSE protocol. First we resuscitate, then we optimize, then we stabilize, and in the last stage E is evacuation. Then we try to remove the fluid from the body. Now this is the last case. A 2-year-old has fall with a history of fall from stairs around 5 feet. The CT was done, which showed subdural hematoma on the right side and fracture of parietal occipital bone. I incorporated a video of the CT, which is not showing. The child was intubated in view of poor sensorium and started on ventilatory support. Now again, the choice of fluid. He is a case of CNS trauma. So which fluid? It should be always DNS. Okay. In head injury, we have to maintain higher sodium concentration. We never use half DNS. Okay, we always use DNS. And if it's maintaining good amount of sugars or dextrose, you can even start in on NS, because sometimes due to trauma, his sugars may already be high. So you just monitor sugars and you can start plain NS, especially in a big kid. Or now in these we use.
In a case of head injury, the child is on 3% NS and the sodium levels go high. In that case, what choice of fluid?
If that will discuss in the hypernatremic. Okay. So you have to see why sodium levels are high. We have a separate class on hypernatremia. So I'll just finish the course. So what is the choice of hyperosmolar therapy? Mannitol or 3% saline? Usually earlier we used to say 3% saline is better, mannitol is a bit low. Okay. But now they are equal, almost equal. But you have to maintain a good sodium concentration. So choice between mannitol and 3% saline will depend upon what is his BP and what is his sodium. If his BP is low, then you can't give mannitol, then you have to give 3% saline. And if sodium, like she was saying, is high, then you can give mannitol. And if sodium is low, you have to anyway maintain a higher serum sodium concentration around 145 to 155, then you can use 3% saline. So difference between mannitol and 3% saline, they are equally good, but will depend upon other factors. What is his blood pressure, what is his serum sodium concentration, and what all other things you need. And mannitol can be given in boluses. You can even give 3% saline in 6-hourly boluses. Earlier we used to give 3% saline as a continuous infusion, but now you can give 3% saline also with 6-hourly boluses. And how much fluid again? Full maintenance or restricted fluid? Why restricted in this case? Increased fluid in a case of CNS will lead to cerebral edema. Initially, if he is in shock, you can give some replacement fluid, but as soon as he start to maintain blood pressure, you have to restrict your fluids. Initial boluses can be given to maintain the intravascular volume and to maintain his blood pressure, but later on you have to restrict it. So with that, we'll move on to hyponatremia by Dr. Bilal. Yes. No, there is no indication of N/6 these days.
We should cut out our scope because we always have been using isopropyl for so much.
So there is no indication of ISOP beyond the neonatal age group. And sorry, I left neonatology long ago. So that is the most common cause of hyponatremia, iatrogenic hyponatremia.
And also neonatology nowadays used to calculate the exact sodium and potassium.
Yes.
Do not go blindly by
N/6.
How much you are giving in each week?
That is same as the mannitol. You can give 5 ml per kg as an initial bolus, then you can give up to 3 to 5 ml per kg 6 hours. Yes, 6 hours. 3 to 5 ml per kg as bolus is 6 hours. Same as the mannitol dose.